All right, thank you all so much for allowing me to present today. My presentation is really kind of a microcosm, more of maybe a qualitative or narrative presentation about the work that we're doing in a tiny little neighborhood in Portland, and the lessons that we've learned as an organization by doing direct care services with people who are at especially high risk of contracting and spreading hepatitis C. Next slide, please. So our program is fairly new. We've been actually funded and operational for about a year now, a little over a year, thanks to Measure 110. Before we were funded and launched, we were a mutual aid project, kind of doing work out of my little one-bedroom apartment, out of a storage unit we paid for out of pocket, and out of our own vehicles. And that was a wonderful experience. And I'm so glad we sort of built our foundation in the spirit of mutual aid. But when we were notified that we got Measure 110 funding, it allowed us to really extend our reach and deepen our work within this community in a really significant way. So our history is, first of all, we're really just a two-person show. It's me and Brandy. Brandy can't be here because she's on vacation. And we met, our history is that, well, for me personally, I worked at Central City Concern at the Recuperative Care Program for many years. So my history is working with people who have a lot of complex needs, especially at the intersections of chronic and acute medical conditions and more of a chaotic substance use. And so we saw sort of some of the more extreme ways that substance use can show up and the way that trauma can impact both substance use and chronic health conditions. And just a really deep poverty that we're seeing worsening and worsening in Portland these days. And so I met Brandy because she came into the program as a patient via the impact team who she worked with at OHSU. And we met in that way. And then Brandy went on to go into recovery using harm reduction. And it's a self-defined recovery that she celebrates. And I went off to get a master's degree in social work. And then we met back again when I started working at RCP when it moved into the Blackburn building. And she was working there as a case manager. So we met again and worked through the worst parts of COVID, the very beginning, the first year and a half, on the front lines in this intense low barrier medical shelter that was serving a community of people who were actively using drugs, who were being kind of like pushed out of hospitals because the hospital system was inundated with COVID. And so what we were seeing during that time, and in the political backdrop was we were trying to unionize Central City Concern, but we won't get into that. It was a very political and intense time, and we were frontline workers, and we were all scared. We weren't vaccinated. We were getting COVID. We were working through outbreaks. We were not prepared for this, and we were watching people die who were people we loved, people who were using drugs, people who were beautiful and wonderful humans who we were working so hard to advocate for within the care systems, who were just not getting what they needed, especially in terms of safe use supplies. So at the pinnacle of that all, we decided we should start doing something about that. Brandy was a PPOP volunteer. We're now very closely associated with PPOP. We share a space with them and love our PPOP friends, Portland People's Outreach Project, for those of you who don't know them. And we learned a lot about safer use supplies. And then we took that and created this program that was both supply and service oriented, where it took my epistemology of trauma counseling, being someone with lived experience, but having a master's degree in social work, Brandy's lived experience, her experience caring for her family, who have all experienced a lot of substance use related issues. And we kind of launched this program. And we can move on to the next slide, please. The communities that we ended up starting to work with the most were, of course, people who are using drugs. Most of the people we work with are using drugs, not all. Most of the people we work with are experiencing homelessness, but not all. I would say pretty much everyone has experienced homelessness that we work with. And a lot of people are sex workers that we work with. And this is sort of the intersections of people we see who um, are both most impacted in our experience by, who are most vulnerable to hepatitis, HIV, and a lot of other things, and also who are the least, maybe our care systems are the least set up to accommodate or to help. And so through our experiences, we sort of started to see what some of the shortcomings or gaps in our local service systems were. And the way that happened was we started working with Cascade AIDS Project to test at our warehouse once a month. We had someone come and start testing for HIV and hepatitis C. And 1 week we tested 13 people in a couple of hours. And out of 13 people, 6 people tested positive for hep C. And only 2 of those people had any idea. The other 4 were shocked and surprised by the news. So we knew there was something going on there. And so the wheels started turning. We started to reach out to see how we could serve these people. And what we discovered was a lot of organizations seem to think that their services will reach these people when in practice, they aren't reaching them. So our folks were, like a lot of people have mentioned today, the transportation issues alone, the inability to have medication, to keep a month's supply of medication, or if it's dispensed weekly, to get to the clinic, to the pharmacy to refill. So there were just so many huge barriers for people who had a hard enough time just getting a couple blocks to get to us in a 3-hour time frame on a Tuesday to get services that they needed to survive, that there was no way we were going to be able to just send them to Blackburn because they weren't going to get there, right? And let's move on to the next slide, please. So what we're actively doing right now to prevent and eliminate Hep C is the biggest thing that we're doing, or one of the biggest things we're doing, is we're really distributing and designing and redesigning harm reduction supplies, or we call them harm reduction kits. So we have several different types of kits that we distribute, and they're in high demand. And we're one of the only local organizations that distribute these types of kits to the degree that we do. We have safe injection kits, which include everything you need from sterilizing, cookers, everything, rigs, everything you can imagine that you need. And we also have booty bumping kits or boofing. We have snorting kits. We have 3 different types of smoking kits. So we have meth pipes, we have crack pipes, and we have hammers for opioids. And then when we don't have hammers in, we have foil that folks can use. So this is really, these are in high demand. The things we give out the most of are, of course, the bubble pipes and meth pipes. And so those are really like the heart of the supplies that assist with the prevention. But we also do wound care and first aid kits, and we have a wound care nurse every Tuesday who is present and has built a lot of really caring relationships with the folks that we serve, to the point where a lot of their medical needs have like minimized. There some weeks no one even says anything except to check in and say, oh yeah, still doing all good. And these are folks that do not trust medical providers and will not go to hospitals unless they're brought there forcibly in an ambulance. So that's been amazing to see that trust building. The other sort of facet of what we do is harm reduction counseling and just like pure conversations. So I'm a social worker and I'm starting to develop harm reduction counseling, which is something that I'd like to expand in the years to come once there's funding for it. And then just pure conversations. Most of our volunteers and staff identify as peers. And so the conversations we have with folks just to ask using motivational interviewing or just using, regular old peer conversations, it's a really powerful thing that we do to just build trust and ask people what they need, and then take those conversations and rebuild the supplies. So we're like constantly changing what the supplies are based on what the need is. just making sure that this remains more of a mutual aid focused project. And then a big part of what we do is community building. So we, being a fairly well-funded program for harm reduction, are able to support other harm reduction programs any way that we can. And we do that as often as possible. But what we see that's missing, especially when it comes to the prevention or elimination or treatment of people who are living with HIV and hepatitis, is what a lot of folks have said throughout the day: transportation, or better yet, going to folks. Outreach is a really important thing, I think, that we need to all be engaging in if we're going to really successfully do this, because a lot of people aren't going to make it to the clinics. Okay, let's do the next slide, please. For us, like what we've noticed, and keeping in mind that we're brand new and we're really just working with a very small population here, but like the narrative, like the more of maybe what we're using is more of like an epistemology that's more based in like indigenous practices or feminist epistemology. The stories we're hearing is like people are not happy with the systems. Like they can't make it into the systems of care. And once they do, they're not treated very well in there, unfortunately. So like for us to know the shortcomings of our own programs, I think is such an important part of what we need to do in order to be successful in the treatment. And then second, like being realistic and flexible, and really informing our approaches in a way that takes into account these incredible barriers that people are facing. And that goes hand in hand with the third point, which I can say the encampment sweeps are absolutely like deeply impacting people's ability to access treatment successfully. And we see that when people are unable to hold on to medications, or even to be located by outreach workers because they can't stay in the same spot for long, right? Like this public policy and the way that public policy shapes people's everyday lives when you're experiencing homelessness have a really deep impact on our ability to show up and offer treatment to folks. Even when people are desperate, like they know their well-being, their health, and their life depends on it. And that's something that I think we need to be as outspoken as we can, given that some of us are limited in how outspoken we can be. But for me, I will just say I have seen, since the camping bans over the past year at least, definitely there has just been a significant increase in people. The first thing I thought of was, oh, all these people that we're working with who are living with HIV need to take that pill every day. What's going to happen? Because they're not going to be able to keep their medications. It just goes so quickly. So like solve problems, like on one hand, being outspoken and like directly trying to influence policy. And on the other hand, like getting creative around how are we going to meet the changing needs when this is the political climate we're living in is so important. And another facet of that is, of course, safe smoking supplies, being something that's really controversial and yet is really the most important tool we have in our toolbox right now. Next slide, please. So that is it in a nutshell. I hope that I know I have a lot to learn about this world. I'm really brand new to the hepatitis C treatment world, but I'm really excited to be here with you all, and I'm hopeful that in the coming years our program can grow and shift and add more data analysis and more partnerships with all of you all so that we can meet this need in a way that's just going to benefit the folks that we're all here to serve. So please feel free to ask questions, comments, or dialogue with me in any way that you feel you'd like to. Thank you.
Thank you, Annie. Great presentation, and thank you for the amazing work you're doing.
Thank you.
I think everybody can tell that the work is coming from a significant place of passion for you.
Incredible work. Thank you.
Do we have any questions? There were not any in the chat, but I would like to open it up for questions. Yeah, Dane mentions that there is safe camping locations in his area, and it really helps bringing services to one spot. It also helps for people to be able to maintain their campsite for the very reasons that Annie so eloquently denoted. Maintaining medications, maintaining personal property, pets, all the things.
I have a question, and for Annie. So obviously the political will towards people who use drugs in Portland has taken a negative turn dramatically recently, which is unfortunate. Is there a place where we can all be aware of like the right messaging that we should be sending to our leaders so that it's all the same messaging, so we're not just, saying things that might not be correct or might not be what the community really needs, it's just what we think, but you're in the streets. Is there a place where you share that messaging that we can all sort of amplify for you?
Messaging specifically around working with people who are using drugs?
Yes.
I mean, I think we're all working with people who are using drugs, like I think there's a lot of people who are using drugs and it's part of life, and there's a lot of different reasons people might be doing that. And I think practicing with compassion and non-judgment is the key to any trauma-informed treatment. And absolutely, even though not all substance use is caused by trauma, absolutely much of the very chaotic substance use is rooted in trauma, and homelessness is very much a traumatic experience. And so people are using drugs to survive. And so I think if we really want to stay true to like low barrier housing first treatment, which we know is the gold standard of treatment, we have to make sure people's basic needs are met, and then the chaotic substance use will likely disappear. It might not look like being clean and sober, that might not be what we're aiming towards here. That might not be what people want, but it will include reducing harm, right? Any positive change. It will include people doing whatever they would like to do in order to see their own health and well-being improve. I know that's kind of hard.
Yeah. But do you think the media and the city have listened to that logic?
I think that most media and politicians don't necessarily want to hear complex answers. They want simple answers. And I think that the reality is that it's never going to be a simple answer for this. It's going to be a really like, let's think about this and really like acknowledge that it's complex and that people are complex.
Well said, Annie.
Thank you.
There is a question in the chat. Lori Hubbard is interested from Deschutes County, just in case you didn't hear that earlier, interested in knowing if there's a harm reduction coalition in the Portland metro area so that y'all aren't fighting for the same slices of pie and funding sources and stuff. Do you know? I can answer from what I know, but I'd rather you answer from what you know. And Andy, perhaps you can speak to this too.
Yeah, we're fairly new to the actually being a harm reduction specific program and leading it. So maybe someone else would be better at answering that.
Andy, are you still on? Andy from Multnomah County?
Yeah, I really asked that question just because there are some long time providers in Multnomah County that have a combination of fixed site and mobile services. And then you mentioned, I think the acronym is PPOP, and that you share space with them. And then Annie just sounds like amazing work, and that you've already identified some gaps that are not being filled by some of these other service providers. We, for a while, had a Central Oregon coalition to both help mentor newer programs and share information and not compete for resources. And so I'm just curious if there's a coordination of those efforts in the larger Portland Tri-County area up there, given that there might be more resources there than anywhere else in the state.
So this is Anne and Chequin, obviously. And maybe Jude could chime in here too if she's still on. There was a statewide harm reduction coalition back in the early 2000s, but when funding got scarce, so did the coalition, and it couldn't stay together. Then there was a unofficial harm reduction coalition of the Tri-County area that would meet unofficially and mutually support each other, but not really talk about grants and things like that in the 2010s. And since COVID, nothing like that has been readdressed that I know of, having been in the harm reduction community here in Portland for a very long time. But I'm hoping to hear from somebody else that actually knows that maybe there is something, or this is certainly something, Lori, that we can talk about having in different areas of the state, because it's absolutely essential that we are talking to each other. And unfortunately, I think keeping the slices of pie, I'm just going to say this, I'll probably get in trouble, keeping the slices of pie small enough such that folks have to compete is part of the issue. And why these very social problems that we're referring, these complex social problems that we're referring to, that don't have an easy remedy, are continuing to occur and oppress people.
Yes,
Yeah.
and the sharing of ideas and strategies. And I know that that's gone on with I think source funding for overdose prevention and response, but and that's fantastic, but very specific to that, as opposed to a wider harm reduction coalition, especially with funded staff.
Oh, Jude said that there is still a harm reduction meeting led by Multnomah County. So maybe that would be something that folks would be interested. Jude, please.
Hey, so, I think there are harm reduction groups that meet in different parts of the states. I think some of them use different names. Lori, one of the things we have not talked a whole lot about is in the next round of our Save Lives Oregon work, there are going to be community meetings. And just to be frank, for the Harm Reduction Clearinghouse, getting ahead of the almost straight up need of entities to join the clearinghouse, get them through with really only actually the 1.0 FTE that we got a grant to cover, that we got from you, the person who we got from you.
I barely forgive you.
Yeah, I know. To serve more than, now we're over close to 300 entities in the clearinghouse with still only one staff person, which her name is Ashley and Jones, and she is not here. She's on a well-deserved vacation. But I think there'll be some potential for groups to meet through the Save Lives Oregon in the coming year. Certainly, as I think the state stands up their opioid and overdose response that I know is in the works right now, that is a collaboration between behavioral health and public health. There will be more space for community, and actually community voice is going to be needed to both lead the work and direct, literally say what work needs to be done and where with who. So I think but it is a back and forth, right? So I think there'll be a back and forth of very similar to COVID, which is, meetings. Here's what we know. How can we help you? What do you need? Here's where we're at. What do you see? How can we help you? What do you need? That led to the formation of the clearinghouse and really the launch of Save Lives Oregon, which there are multiple people here who are involved, including Dane from HIV Alliance in that. I just, you know, I know, Annie, you guys are amazing and you do amazing work. And it has been a joy to watch you, even though I know it has been a struggle to stand up and respond and listen to the community that you work with and serve them.
Thank you.
And if
Julie.
I could just see if I can wrap this up, my part succinctly about this is that I think that some of the coalitions that are very focused on overdose involve parts of the system, institutions that have differing lenses, views, approaches to harm reduction work. They come with what they know best and what they do best. I think I really appreciate Annie's anti-racism, anti-oppressive views and identifying of gaps. And that's why I kind of think like the overdose work that's going on and those coalitions and those coming together of different sectors is fantastic. But I also think like in Central Oregon, we created one that was very separate, specific to harm reduction, where we could share lots of different ideas and also talk more freely about these oppressive structures that really get in the way of helping people stay as healthy as possible.
Yeah, I mean, I agree, Lori. I think that people survive despite our systems, not because of our systems often. And I think that hopefully that is something that we can talk openly about, particularly with, you know, the work that's happening. I think we're at a pivotal point in both the epidemic of polysubstance overdose and our response. And I think when I think about the work of Save Lives Oregon, and we're not really speaking about that today, but to bring people, I watched Dane, who exemplifies it, bringing people from awareness of what harm reduction is to allowing harm reduction to happen in their communities to supporting. And I think it is a hard slog. I know Dane can probably, he makes it look so easy, and I know that it's not. And Annie, I think sometimes, you know, I watch people who've been through it. You've been through the fire and people are watching, and I know how hard it has been to do that work. And I think we have a lot of hard work ahead of us in Oregon. I don't know how much people are aware, but we are looking at it. And I see Randy here. Randy Blom is not speaking, but he is another person that says, what do we need to do? And then goes out and figures out how to do it. But I think that we are looking at a 22% increase in overdose deaths in the next year. 22%. The rest of the country is looking at 2%, 2.5% from CDC. That's the estimates. So I think as we talk about syndemic work, I think we need to figure out how do we have harm reduction conversations, and we'll have one later in a small group, but we have to figure out how do we not eat our young? And I know that, and how do we bring people along knowing that it's a big tent and some people are just standing at the edge